Hello, good night, everybody. Hope you are all okay. Today we'll discuss role of hysteroscopy in the treatment of infertility. Today, my guest is one of my very good friend, Dr. Rinoy Sridharan. He's basically from born in Kerala, now working in Mumbai Indira IVF Limited. She is a chief consultant in Indira IVF. Actually, we have the opportunity to learn each other from Delhi in the IVF. So let's introduce Dr. Rinoy Sridharan.
Hello, Dr. Anam.
Hi, Rinoy.
Hope you're doing well.
Oh, fine. How are you?
I'm good. I'm good. Thank you for this opportunity.
Okay, thank you. What is the condition in Mumbai?
It's improving.
Okay.
Yeah, the case numbers new cases are going down. So I guess maybe in another 5 to 6 months, we'll be totally out of it.
Okay, very good.
Yeah.
So today we'll discuss the role of hysteroscopy in the treatment of infertility.
Yes, I remember we had done some cases together back when we were in Delhi.
Okay.
That's I think it's over 4 years now since we.
Right. Over 4 years, and we have a great opportunity to see the Parwala Guli, Parota wala Guli.
Yes.
You remember the Parota wala Guli in Delhi?
Yes.
Yeah,
I remember it.
So let's start the role of hysteroscopy in the field of actually in the treatment of infertility.
Yeah. Yeah. So basically, as we all know, you're practicing infertility. I'm also practicing in infertility line, and we know that the most important operative tool, if we just think of it, is probably the hysteroscope. Now, if you look at the history of the hysteroscopy, then it's been around for maybe you can say maybe 100 years, and it has evolved over time. And as it has gone ahead, it has become more accessible and more patient friendly. So today we'll be discussing not just hysteroscopy. I'll be just touching upon the role of ultrasound as well prior to the hysteroscopy and how it helps us and how it improves outcomes in whenever we do a hysteroscopy. So these are the broad headings under which I'll be discussing this topic today. One is hysteroscopy and imaging in general, not just 3D imaging. Hysteroscopy in IVF cases. I'll be discussing hysteroscopy in IUI cases as well. And then for the management of uterine pathologies like myomas, polyps, intrauterine adhesions, then I'll be looking at difficult entries, then hysteroscopy in repeated implantation failures as well. So, Dr. Anam, do you do your own, do you do the ultrasound for all your patients by yourself, or you send them to a radiologist?
Yeah. By myself, actually. In my center, actually, I prefer always, it's basically ultrasound-based management. We stress a lot of importance on transvaginal ultrasonography. So I do believe, actually, every infertility specialist must do transvaginal ultrasound of her or his own patient. That can actually optimize the actual success rate. What do you say?
Yes, very true. Because unless you see it yourself, I think we would be able to do justice to the patient if we were to see the patient ourselves and do the scan ourselves. So as time has passed, of course, we are all adept in doing 2D imaging. That is basically the grayscale normal. But now with the advent of 3D, a lot of more pathologies we have been able to make a more strong diagnosis and not a presumptive diagnosis just by doing this ultrasound. And we do not always have to resort to a hysteroscopy. We can avoid unwanted hysteroscopies just by this simple 3D imaging. So I'll just so this is the question: how does 3D ultrasound help in decision making in today's infertility practice? So now, just to start off with, this is something that we do come across in our practice: a normal uterus versus all these uterine anomalies. So as you can see from left to right, you can see a unicornuate uterus, you can see a complete bicornuate, You can see a septate uterus and complete septum, arcuate uterus, T-shaped uterus. So on and off, we do see these patients presenting with infertility or even recurrent pregnancy losses in our clinic. So often, maybe I remember when I had joined my post-graduation, that was around 10, 12 years back. So back then, we only had we would only read, diagnostic hysteroscopy and laparoscopy. That is a gold standard for diagnosis of.
Can you use your microphone, headphone? Yeah. Actually, sound is a little bit.
Yeah. Hello, I'm audible now?
It's louder, right? It's better.
Yeah. So back when we were doing our post-graduation, so we used to hear that the laparoscopy diagnostic and histoscopy are like the gold standards for diagnosis of uterine anomalies. But slowly, there was always the need for something. There was, which would diagnose things in a less invasive way. So of course, 3D imaging was available back then as well, but in certain centers only. But now, like, it's there at most cities in India, and therefore it does away with a lot of unwanted laparoscopies. For example, if you consider the septate uterus, earlier we used to say that the ideal management for septate uterus is septum resection, and it should be guided by a diagnostic laparoscopy. But we have been able to, overcome that and do these septum resections without laparoscopy, provided we do a proper, well guarded. We shouldn't be overzealous in our approach. So of course, these uterine anomalies can be tackled for most parts just by a histoscopy, and it will definitely improve our outcomes. Now this is like, you can see these two pictures which I've put up. One is a polyp and one is a myoma. We shall be looking into the management of this as well later on this evening. And another thing that I think is of which is very dear to your heart as well is this saline infusion sonography. Dr. Anam, you practice it quite a lot, I'm sure. Hello. Hello.
Rinoy.
Yeah.
Carry on.
Yeah. So do you practice?
Actually, I mean, I'm really fond of the saline infusion sonography, as you know, because yes. I do believe actually saline infusion sonography as equivalent to diagnostic hysteroscopy. I do believe. What do you say?
I wouldn't rely on it completely because, of course, now as you can see in this picture, it is nicely delineating a fibroid, and okay, you have to do a histoscopy. And in sometimes when you have suspected polyps and all, it really does help in distinguishing and telling us. It gives us a lot of information. Definitely, I agree that it is a very powerful tool, but for me, I wouldn't say it can replace histoscopy, but yes, it is a very powerful weapon.
As equivalent to, actually not replaceable, but as equivalent.
Yeah, I would just say maybe things like micropolyps and other features of uterine infections, chronic endometritis, that are the things which could possibly be missed by an SIS. Otherwise, most things, of course, you can let it be adhesions, a septum, anything you can actually catch with this saline infusion sonography. Yes, that I agree with, Dr. Anand. Okay. Correct. So moving ahead, now we'll just see some evidence, a little bit recent, which comparing means touching upon the use of 3D ultrasound in routine gynec practice. So this is a paper published in 2010, which said that 3-dimensional ultrasound in the diagnosis of Mullerian duct anomalies and concordance with magnetic resonance imaging, that is MRI. So some time ago, we used to always advise for an MRI. Still, when we are nowadays also, when we suspect some complex anomalies, we do advise for an MRI. But for other things, we can, of course, first do a 3D ultrasound because it has a high degree of concordance as shown by this paper. And of course, for all cases of suspected Mullerian anomalies, we should do a 3D USG. And if we only suspect complex anomalies, should they be subjected to an MRI? And I had made a point regarding the need of 3D USG. It's, in fact, some papers suggest, like this one published in 2012, which suggests that 3D USG is the only mandatory step in evaluation of Mullerian duct anomalies and intrauterine lesions to assess the need for hysteroscopy. There was one more paper which said that it has a very important role in improving the success rates of surgery. So today, if you're doing a gynec practice, infertility practice, then definitely it can be a very powerful tool to improve the success rates of your surgery. So that was regarding with regards to the imaging technique that we commonly employ. Now let's move on to the first line of treatment. It means actually we do natural planning and assist as part of the initial approach to any infertile couple. But then the next step that we take is IUI or intrauterine insemination. So this is mostly how a patient is taken up for an IUI is they've been married for quite some time. They've tried assisted natural planning also, but they have not been successful. The tubes seem patent, and your 3D ultrasound might be fine. So then you plan to go for an IUI. Now you do maybe one IUI, two IUIs you do, but still no success. So there was this question which arose of you. What is the role of hysteroscopy before an IUI? So there are some papers which studied hysteroscopy before IUI. Even I was surprised that people have studied that, and the result was quite shocking to me also.
Okay.
Yeah, this was a small study, of course. It was in which 180 subjects were included, and out of this, 41% had abnormalities on hysteroscopy. They are an apparently normal ultrasound. This was done in Libya. A small study. Of course, larger studies are warranted, and they found out that all the patients in the hysteroscopy group conceived in 2 IUI cycles. So, of course, I think that does help. So the commonest abnormalities that they found was there were some minimal adhesions, then around 4 to 8% had septae, had a septum, and some had around 8% had chronic endometritis. So slowly evidence is coming up with regards to this also. There's one more paper which I've not put up over here. That's also an Asian paper. In that also they had a small study group of IUI patients, and some were subjected to hysteroscopy, some not, and they had showed that the success rates are higher in the IUI cycles. So maybe with the passage of time, this could become a mandatory thing. You cannot say. Okay, so have you had any experience like this previously, Dr. Anam, wherein you've done just a hysteroscopy?
Right. Especially, actually, we do actually not after 2 IUI. Actually, firstly, we do at least 4 IUI. Then actually we evaluate for hysteroscopy. Then whether this is
okay. So do you do just a hysteroscopy, or you combine it with laparoscopy?
Not all times. If there is a suggestive of actually in infertility practice, there is a little role of laparoscopy, I think.
Very true. Very true.
So, in case of infertility, not all the time that laparoscopy and hysteroscopy both I do.
Correct.
Yeah. But, what is your opinion actually?
Yeah, I totally agree with that, because many times we do the laparoscopy, diagnostic laparohistro, and the findings seem normal, and your unexplained infertility cases still remain unexplained. You still have the 20%, 30% cases in whom there's no outcome only, and we continue with the
unexplained infertility. What I believe is not the peritoneal factor or tubal factor. Most of the time, it's actually sperm dysfunction, I think.
Yes, very true. Many times,
there is no test of sperm dysfunction. So, what is the role of laparoscopy or hysteroscopy there? That I believe.
Yes. So we'll be looking at another thing, that is your hysteroscopy before the IVF cycle. So do you do hysteroscopy for all your IVF cycles, Dr. Anam?
No. Not all IVF cycle.
Right.
What is your opinion actually?
Yeah. I also concur with that. We also have this approach where we don't do IVF, pre-IVF hysteroscopy for all our patients, because what the common evidence that suggests is that there is no actual added advantage in all your cases. So this is an insight trial which was published in 2016 in Lancet. It was a very strong trial. which concluded that women with a normal TVS should not be offered routine hysteroscopy. So we've
That's
done an
actually
ultrasound.
that's I believe actually that's I
Yeah,
really practice in my infertility
correct.
cases.
Correct. So there were other papers as well. There's a this is another strong bit of evidence, that is a Cochrane review, which included 11 studies, which showed that performing screening hysteroscopy before IVF does not improve the clinical pregnancy rate or the live birth rate. So definitely doing that without any prior indication, in those cases, we do have a slight differing approach when we have a patient who has had a previous failure without any hysteroscopy done. In those, of course, we do prefer to go ahead with the hysteroscopy and then transfer. Okay, now when we are coming to the hysteroscopy, the actual practical aspect of it, I just wanted to know what diameter of scope do you use?
2.9 actually.
Okay, so you're probably using the Bertocci scope.
Yeah.
Yeah, same. We also use the same one. And what is the distension media you use?
I am using the bipolar system, so normal saline is the distension media.
Okay, great. So same that we also do over here. We use normal saline, and there's one like, how do you recognize and prevent fluid overload? This is a question that always plagues us. How do you how do you manage the fluid system? How do you know that too much of fluid is going? Because when you're operating, you cannot pay attention to each and every aspect. So we usually say that if you're using, especially when you're using the resectoscope, you need someone who say a scrub nurse on standby, who would tell you that, okay, this much fluid has gone in, this much has come out, and the deficit should not be too high. So that will definitely help in preventing fluid overload. So that's how we generally work. But whenever we're using the cold scissors, the hysteroscopic scissors, 5 French, so that most of the time now, with time, we have definitely reduced our operating time. So we are generally done within a few minutes. So there's not much of chances of fluid overload. And this is an AGL position statement regarding distension media. So they say that uterine cavity distension pressure should be the lowest pressure necessary to distend the cavity. Saline has a better safety profile. So we are already, I think, maximum practitioners are using saline only. And excessive absorption of any media can cause complications. Like, for example, high viscosity. If you have a deficit of 500 ml, that's an alarming sign. Hypotonic 1000 ml. If you're using normal saline, you can use maximum up to, say, we raise an alarm at 1000 ml, and if it goes beyond 1500, we stop the surgery and we postpone it. And in the meanwhile, we ask the anesthetist to give some furosemide as well, as to flush out a little bit of fluid. So going ahead with the uterine pathologies, so we shall be looking at polyps, myomas, and intrauterine adhesions. So I've lined up some cases which we have seen in our clinic. So this was a 33-year-old lady, married since 6 years, with history of intermenstrual spotting, and of course she has infertility, and her ultrasound shows a single hyperechoic lesion in the endometrial cavity arising from the fundal wall of size of around 2 by 2 centimeters, and this is the scan finding. So this, if you look at it, this is a nice 2D picture which is showing a hyperechoic lesion. So this is most likely a polyp, and this is somewhat what it looked like. So we had posted the patient for a hysteroscopic polypectomy, and post this, we just helped her conceive with just IUI, as far as I remember. She had conceived with that, and this intermenstrual spotting as well was taken care of. So the only thing is, now most of the polyps we are able to do with the scissors. Earlier, means it's just that in some cases of fundal polyp, you can, even if it's like big fundal polyp, you can prefer to use a resectoscope also, but that is entirely user based. It's not necessary to, if you're able to take it off without
Yes, I always
resectoscope.
prefer actually cold knife, because I think cold knife is better.
Yes, it is. So let's just have a look at the AGL practice report regarding management of polyps. So they said hysteroscopic polypectomy is a gold standard. Yes, medical management, this is with respect to general gynec practice as well. And of course, when you remove it, you should definitely send it for histological assessment. Now, coming to something that there is always a question, I have a small polyp, it is like low down in the cavity. Do I need to tackle it? So generally what we personally believe is that we do not tackle polyps which are less than 1 centimeter and all. We just let it be unless they're in the middle of the implantation area as such, the implantation zone which we generally say. And there are different papers which are showing different sizes of polyps. Some say 1.5 centimeters, some say
5 centimeter polyp need not to remove.
yeah, so different papers are there, but we generally anything more than 1 centimeter we prefer to remove actually. And yeah, there are different varying evidences on this. Okay, so let's move on to the next question. That is a 35-year-old lady married since 7 years, eager to conceive, and she has visited your clinic. Her cycles are regular, AMH is like normal, and bilateral tubes are patent, and semen parameters are normal. And we did her ultrasound. That was the 2D picture, which is showing submucosal hypoechoic lesion, well rounded. And this is a 3D picture. So, what do you feel this is, Dr. Anam?
This is the fibroid, fibroid intracavitary fibroid.
Yes.
Fibroid is completely within the uterine cavity.
Yes. So this was basically almost a type 1 in a submucosal fibroid, and we ultimately managed
T0 fibroid.
Yes, T0 T1. Yes. So this lady we had managed histoscopically, and she had a good outcome, and we had done it with a histoscope only. We finished it off in one setting. Now there are some.
Is there any size limit that T0 fibroid? What is the size limit for doing the
T0 fibroid? You can actually manage it completely in
whatever may be the size.
Yes. And it's just that it's just that when you have large fibroids, if you have associated say anemia, then you can just give them GnRH agonist. It might help in reducing the size also a little bit, but mostly they can be easily managed by a single setting also. It should not be much of a problem in T0 fibroids because they're generally connected. They are totally submucosal, right? So they are in your view. It's only when it goes to say T1, or not even T1, means when it goes to type 2 or type 3 that you cannot manage it. Type 3 of course not, but type 2, if it's like it has a good component, and if you feel that it's going to take time, then it's better you can think of approaching it laparoscopically. If we have a laparoscopy discussion later on, means some days ahead, then I could show you one of those cases which we had done, wherein a same fibroid was managed histoscopically, and some component of it was still left, and patient was just not conceiving with all rest everything being in place. So we went ahead. There was still a 2 to 3 centimeter component which was which always grew over time, and it was on the posterior wall. So we then removed it laparoscopically, and patient is now currently, she is pregnant. Okay, now let's have a look at the recommendations for what AGL has to say regarding management of submucous fibroids. That first and foremost, like we said at the start of this talk, that surgeon should personally evaluate the USG images prior to the surgery. And cervical preparation can be done, which reduces the requirement of dilatation. So do you use any prior cervical preparation like misoprostol or anything?
I use misoprostol 2 or 3 hours before actually procedure.
Okay. So do you ever find that with the cervix has become too soft and
it's magic actually, tremendous tremendous change of the cervix. Even what I have seen, I put one patient's misoprostol just at the night, and in the morning, whatever the cervix is just like dilated like liver. So I can put saline also. It's very difficult to put the saline. What is your opinion on the
Yeah, so if you use misoprost, then that problem may arise, but but it definitely has its advantage. So I feel that if you have a very small cervix which you feel can have some difficulty in dilatation, then only should we use misoprostol. It's not for every case, is what I feel. Then moving ahead, AGL also said that you can use GnRH agonist, which can help in treating the anemia. Now, anemia with respect to submucosal fibroids, because of the surface area increase, they may have some continuous bleeding, menorrhagia may be there, which may lead to anemia. Post-op adhesions can be evaluated by second look hysteroscopy in multiple submucosal myomas. So sometimes you have patients who have multiple myomas. One may be on the anterior wall, one may be on the posterior wall. So when this sort of picture is there, we might be able to resect out both the means remove both the myomas in one setting, but there would be an apposition of raw surfaces. So you will have to look at them again. You can reevaluate them by having a second look hysteroscopy. And in our setup, what we generally do is we use a 10 number Foley's, we inflate it to 2 ml, and we leave it for around 5 to 7 days to prevent the chances of post-operative adhesions. However, there is a school of thought which says that leaving in a balloon is not always a good idea, as it might hamper the epithelialization of that surface. So that again needs to be studied. And this AGL also said that deep type 2 myomas can be removed laparoscopically, like the case I was suggesting. Now, this is a very interesting instrument. It is called the Histoscopic Oscillator. It's been around for, I think, quite a bit of time now.
Have you ever shaver, I think?
Yes. So there are 2-3 companies which make this hysteroscopic oscillator. It is a bit of a bulky instrument. It used to come as a quite bulky.
To meet relatives in Malaysia. He's a very nice person. She's Italian guy.
Okay.
Good. I have seen his 4 surgeries also.
Okay.
Big myoma he removed with his shaver.
Okay. Yeah. So the only hampering factor in the routine use of this instrument would probably be the cost. Don't you think so, Dr. Anand?
Yeah. What do you say?
The cost would probably be the
very costly because it separates actually setup. It has different type of instrument and it has different insufflator also. So correct. You need a lot of money. That's the problem. But I think it's a very good instrument. I personally, in a training program, I use it. That's good, actually.
Yeah, it actually reduces the operating time and it's easy to use, basically. So there was a study regarding the hysteroscopic modulation of submucous myomas as well, which is published in 2017, and which said that you have a shorter operating time for type 0 and 1 myomas. You have a shorter learning curve. That means someone who's not so proficient in doing hysteroscopies can also, by hysteroscopic myomectomies, can also go ahead and perform one effectively. And there is, however, no superior outcome in comparison with classic resectoscope technique, which you and I use. And of course, the most important point, it is not cost effective. So maybe later on, when it becomes very commonplace, then probably we'll be able to use it regularly.
Right.
Okay, now another question. 37, this is another case. 37-year-old lady with history of repeated miscarriages and dilatation curettage done multiple times, posted for diagnostic histoscopy. And her ultrasound had showed a thin and irregular endometrium. So to whomsoever is listening, this a few days back only, I was discussing with Dr. Anam this particular case which we had seen. And we were just telling, is there anything that you use, or is there some magical drug for this thin endometrium which does not even respond? So we'll be talking about that later. So let's just see what her hysteroscopic picture was. So it was something like this. So basically, this is what Asherman syndrome, or this is the intrauterine adhesions. So this and the pathology, if you go back to the history, is probably the repeated dilatation curettage that was done, as it is a blind procedure, and it can definitely give rise to the raw surfaces, which because of too much scraping off of the basal layer. I'm sure you have seen such cases in your practice, Dr. Anand.
Right. Asherman syndrome is, I think, more common actually, Asherman, because the unnecessary DNC actually causing the damage of the endometrium.
Correct. Very true. So this is what it looks like, and I'll just this is a very simple case. Minimal lateral and fundal adhesions. If you see those bands, like you can see at the fundus. So basically, when you do a hysteroscopy, the thing is you need to be able to see both the ostia and a nice, almost a flat fundus, or maybe with a minimal dip, the fundus should be seen. So that is basically something which is suggestive of a normal uterus. If you're not able to see both the ostia in a panoramic view, that means there is definitely some amount of adhesions.
Right.
So, and you have to tackle it histoscopically. So this is.
So this type of adhesion, you also prefer the cold knife, I think.
Yes. Totally. We are quite okay with working with a cold knife now. And another thing that we do when we are tackling cases of dense adhesions is that we do a proper pre-operative USG, and during the procedure as well, we keep the bladder full. Once entry is gained, we keep the bladder full, and we go ahead and do a little bit of cutting, but under ultrasound guidance, transabdominal ultrasound we do, and then that helps us, give us a idea of how much thickness is remaining in the myometrium, so that the
Okay.
chances of perforation are minimized. Otherwise, there is a good chance that you may perforate, because there is hardly any vascularity in most cases of dense adhesions. As a result, you might just go ahead and perforate the uterus, so that we can avoid just by doing a simple,
In the type of addition, there is a role of concurrent laparoscopy.
Yes, you can. That depends on what stage of treatment are you in. Like, I have seen some cases wherein they had this history, plus there was no tubal pathology. It means there was, of course, tubal block was also there, but then this as shown in previous USGs. But in some of them, what we saw, in many cases, what we saw is that there was hydrosalpinx, or very inflamed tubes, signs of PID. In many cases of this Asherman's, whatever grade it was. I'll share a case with you later, which had a similar
Okay.
history. Yeah. What AGL has to say regarding management of intrauterine adhesions, they say that histoscopy is, of course, the best for diagnosis over an HSG and an sonosalpingography. MRI is not recommended. And how to prevent secondary adhesions, they said that you can use an intrauterine device or catheter, except copper and progesterone IUDs. Because earlier there was a practice of keeping copper teas inside the uterus after adhesiolysis, but copper by itself is something which can give rise to adhesions. It causes a
Right.
lot of inflammation,
It's always
which is the
actually
basis.
better to put the lipase loop. That's actually not so
Yes.
much
Replace
available
loop is
nowadays.
there. Yes.
Mm.
It's not available because its primary use for contraception is gone.
Gone.
So it's not. Yeah, it has
Uh,
been replaced. For that reason, we cannot use this. So post the surgery, how long should we wait before we give any sort of treatment? So ideally, you should wait for up to 2 to 3 cycles, wherein you will be, giving them pills to get to regularly cycle. And what estrogen do you use, Doctor Anand?
Actually,
Post
I
the surgery?
personally use estradiol valerate. Actually, I am using because it's
Okay.
little bit cheaper. But
Yes.
here
Yes.
using conjugated equidistrogyn a little bit costly, I think.
Yes. It is comparatively, it is on the higher side, the cost.
So
So
why conjugated estrogen is better than the estradiol valerate?
it is the more, yeah, it seems to be the more potent of the estrogens, most potent of them, the conjugated equivalent.
Okay.
So that is what is recommended, up to 2.5 mg. So it basically comes as Premarin. That's the only brand I know of.
That's when per day
And
3 tablet needed. I think three
yes,
tablet needed per day.
yes. 0.6 to
So
5 is the
you will
dose
give it a
per tablet.
continuously 3 cycle or cyclically.
No, we give it cyclically. We give it cyclically, and
So
the patient waits in between.
if you giving only estrogen or with the progesterone also, you're putting.
No. We give later on in the cycle. We do add progesterone, so that she gets her regular cycles. Plus, we
Okay.
can that helps in timing also slightly better. So we give it 0.6 to 5. We don't give a dose more than. We don't give up to 2.5 mg. We just give max say 2 to 3 tablets a day. We don't go beyond that, and we give it for say up to 20 to 25 days, and
So
then we
what do
add
you
some.
say about the catheter? Which number of catheter actually you put? It is a
We are
pediatric catheter,
using
I
10
think.
number. Yeah. We
Huh?
use the pediatric. Yes, pediatric Foley's 10 number. We just inflate the balloon with say 2 cc of saline, and then we just reduce the tip also a little bit. We
Hmm.
cut off the tip a little bit, and then we introduce it. And we usually do it under ultrasound guidance only, introduction of the catheter. And and we generally remove it after 5 to 7 days. So
So
that's how
in
we.
that time, if you put the catheter, you have to put also antibiotic, I think.
Yes, we do give antibiotics post the surgery. We for 3 to 5 days we do give a course of antibiotics, so it really helps. Yes. That is very
Whether
necessary.
patient complain any pain after putting the catheter when patient
Actually, I have seen personally that they will complain of a lower abdominal pain or a backache very commonly, if you inflate it more than 2.5 ml, is what I've commonly seen.
So how
you
you
can
fix the balloon? You fix the balloon. How you fix the balloon actually?
you can see, actually there is no foolproof method to fix the balloon, because the only way you can fix this is either you'll have to tie it inside the uterus or to the cervix. But
Uh,
many times what happens is with movement, it just gets pulled out, because many times post surgery also these cervix is soft because of manipulation and all. So as a result, it just slips out. So what you can do is you can fix it to the thigh, of course, but ultimately reintroducing it is quite painful for the patient also. So we do not reintroduce it. We make sure that it stays inside, and managing the volume also inside it. Okay, so we'll move ahead. So, 27-year-old lady with primary infertility of 5 years, and AMH is 5.2, and this is what the ultrasound showed. Now, so this is basically, it looks like a septum, correct? If you can see this 3D ultrasound, this is the advantage of the 3D basically. Now,
right.
earlier we would have just seen the two cornus, and we would have to make a guess with a 2D ultrasound that, okay, maybe this is septate versus bicornuate, and treatment diagnostic histolaparoscopy. That is how it would have been, correct?
Right.
And but now with the advent of with the easy availability of 3D ultrasound, now we can do this history. We can map what is the thickness of the fundus, at where is it. We can even check the vascularity. We can check the lateral thickness. So a lot of information we can get pre-operatively itself. So it's an amazing thing, this 3D ultrasound. So we can use this. We can manage this case completely with the help of a resectoscope. So I have a small video over here wherein there was a complete even vaginal septum. If you look, that was a vaginal septum, and this is the cervix. This is on the right side. That was the left side. Here we'll enter. Yeah. So this is one side of the cavity, and that was the vagina again. So this another thing that we commonly do is we take this Collins knife and we make a small nick in the mid part of the septum. We don't start at the extreme base or at the extreme fundus, because it now gives us a view into the other side of the cavity. So and then it gives you So basically, you
But
will
in
cut
that
you.
type of cases, some surgeon prefer to put the balloon in one cavity than
Yes, that I
under
have used that
balloon
myself.
guidance.
Yes, it's wonderful,
Okay.
Doctor.
Exactly.
Yes, it's a very good tool. You can put
Good,
the
very
balloon in
good.
the. Yes, yes,
Then you
yes.
can actually
It
stay in
provides
a
a little bit of hemostasis as well.
right.
Yeah. So this, you can manage this in this manner, and how the things that we have to be careful about is while managing this septum, we should not be at the fundus. We need to leave about some amount of thickness should be left out. You
Right.
don't have to overcorrect it and make it balloon out. Otherwise, what happens is there have been cases of uterine rupture reported
Right.
somewhere in the third trimester. So it is not very good to reduce it in such a way that there is no boundary left, or there's very thin myometrium left, because it takes time to heal, and you have to give
Right.
at least 2 months for this if you're managing a complete septum. So if you don't have a good ultrasound machine, then of course you can any days you can do the laparoscopy, and if you're in your initial cases, you can do the laparoscopy so that you're double sure that you have not perforated or any sort of fear that you may have. You can just take care of it laparoscopically. Now, let's have a look at the guideline given by the ASRM, which was published in 2016. So basically, they said if you resect a septum, you have improved pregnancy rates, improved live birth rates, and reduced miscarriages in infertile women. The length or width of the septum does not affect the obstetric outcome much, and you have to wait for around 2 months post the
Here I
surgery.
have to ask a question. When in an evaluation you are find that she has a uterine septum. So
Mm-hmm.
if she can try naturally that she can conceive or not, then if there is
Yeah,
a
see, there have been cases. I remember seeing once when I had done a rural practice also. I remember seeing a patient who had she already had a kid, and the child would always deliver by it was a breech delivery, the first one, but no one noticed it. that she had a septum also. So we cannot say how much that septum contributed, but there are cases. Basically, what is said is if the some studies say that if the embryo implants on the septum, not on the lateral wall of the uterus or anterior or posterior, if it implants on the septum, the vascularity may be disturbed, leading to pregnancy losses. So most of these cases have that classical pregnancy loss, and of course, this is more applicable in cases of more, septums which include more than half of the cavity.
That's the
So
thing. Actually, I think the if you in a diagnostic evaluation, you are finding a septum, arcuate, whatever may be the anomaly, she can
yeah,
at least a 3-4
yes,
cycle she can try for natural conception. I think.
yeah.
Then
See,
if she
like,
unable to conceive, then you can try surgery.
yeah,
What you say?
yeah. If it's a small septum, you can think of you can do the endometrial volume, and probably vascularity and all these things can be checked, and you can go ahead and avoid doing a surgery. That is if you have not already taken up her up for hysteroscopy. But if you have taken her up and you see that septum, it is better to correct it. It's since you're already in,
Even
of course.
I did a very interesting surgery. I did
Mhm.
one vaginal hysterectomy, second degree prolapse, uterine prolapse
Okay.
with
Okay.
cystocele and rectocele patient.
Okay.
So she had a 3/4 child and one cesarean section also she had.
Okay.
But nobody actually evaluated. She had what happened during the surgery. One my
She might be having a vaginal septum.
register was doing the surgery, but she can't find the plane of the bladder. So she
Okay.
called me, and I have gone that I find that there is a complete vaginal septum,
Yes,
two
yes, I
cervix,
understand.
two uterus. So it is complete uterine diidal phase.
Okay.
you know so I did this type of vaginal surgery, but nobody knows whether she has no problem in conception, so she has no problem in the delivery, and
Okay.
that type of interesting case can happen.
Yes, yes, I totally agree. Diidal phase, actually, what we do is diidal phase or even bicornuate. We just see which side is more roomier, and then we unify it. Sorry, not unify it. Then we just do a diagnostic histo and we come out. So that yes, but it does pose a diagnostic as well as it is a treatment challenge definitely when you have when it is associated with infertility. Okay. So let's look at what are the common complications that we see in cases of uterine septum. Synechia, that is adhesion formation 2%, perforation is around 1%. You have a chance of uterine rupture of around 0.7%, and cervical laceration if you are holding the cervix too many times or you're not handling it properly. Another thing with the septum is that whenever you take a case up for septum, we usually counsel the patient that there may be the need for a second setting as well, because it may not necessarily, there is some degree of septum deformation many a time. Have you ever encountered that, Dr. Anam?
Yeah, it's true.
Yeah, so I remember this particular case where she had around 6 to 7 pregnancy losses, and she had a very thin endometrium. And we had gone in, we had seen the septum, and we took care of the septum. It was a complete uterine septum. It was not there in the vagina, and we did the septum resection. Then we saw her again after I think around 3 months later. Then she had reformed almost. More than half of it. It was more than 50% of the cavity was covered by the septum. So, of course, reformation also can occur. So you have to counsel the patient prior that a second look may be needed. Sometimes, of course, if you have fluid overload or any other complication, you have to tell them that there is a chance of this as well. So you may have to go for a second setting. Now, this is a topic which I am sure all of us have gone through. We must have experienced this at some point of time or the other, and even today, I wouldn't be surprised if anyone has a difficulty in entry, because you do occasionally get a case where there is either too much deviation of the cervical canal, or the internal losses like stenosed or something of that sort. So, how do you
Whether
deal
you
with difficult entry?
prefer in case of entry by holding the cervix or non-touch technique through
No,
vaginal.
we mostly we do the entry. We sometimes rarely do we use the vaginoscopic entry. We mostly hold the cervix with an Ellis or a valsellum, and we enter. It basically reduces the time to entry, plus when you do some sort of when you're doing a septum resection, or when you're doing some polyp removal, it just gives us some sort of stability. In the otherwise, sometimes when you hit the myometrium, if the uterus is mobile, it reduces the ease of surgery. So you can definitely, it's not necessary to hold it very tightly and pull it, give very strong traction, but just applying a minimal traction can definitely work wonders and improve the time that you take for your surgery.
But if you
Okay,
used
so
to, I think previously actually I was also used to hold the cervix routinely. But nowadays I am also trying the
vaginoscopy,
technique. But this is
no
also
technique.
very good technique, I think. And
Yeah,
it's also very
yes,
good.
yes, it is. So this is just a situation. You're called to the operating room by a colleague. So since you're a professor in your college, so definitely this is a very common occurrence for you, I'm sure, that you're called to the operating room, who was performing a hysteroscopy for a suspected polyp, as he's unable to gain entry into the uterine cavity. How will you manage the situation? So, yeah. So I'm
Yeah.
sure you have always come across, means you
That's a
quite
common
often come
thing.
across this situation. Yes. So
No, most of the time because juniors are actually not used to the 30-degree telescope. No,
yes, yes,
hysteroscopy is a 30-degree telescope, so she or he must be oriented like that. It's a
correct,
matter of
correct.
experience, I think.
Yes, yes,
When
yes.
you have a
So,
number of cases more, then you can actually easily enter, I think.
yes, yes, very true. So, what are the basic tips to avoid a difficult entry? First of all, I would say is that you should not panic.
Yeah,
And
that's true. If you
yeah,
got panic, then it become
yes,
more complicated.
very true. So,
Uh,
no need to panic. You do a good per-vaginal examination should be done prior to the histro. Even if you're not able to get it through, the patient would be on an empty bladder. So you can easily do a per-vaginal examination and try to find out the direction of the uterus. Because sometimes in case of previous surgeries or endometriosis, there are cases wherein the uterus is pulled up or it is deviated, which is the reason why you're not able to negotiate it. So definitely doing a per-vaginal examination could help you straighten out the cervical uterine axis. That can be done by just holding the cervix with an LS. Then follow the direction of the cervical crypts, because if you see very carefully, that the cervical crypts generally slowly lead up to the opening of the cervix or the internal os. So definitely you just wait for the fluid to fill up, and the os will open by itself. And of course, maintain proper orientation of the scope of the internal os.
is
So
there
if you're
any role of Hager's dilator in that type of
I
difficulties?
personally do not prefer to use a Hager's dilator. I rarely use it. I use Hager's dilator in my practice only for one thing, that is to prior to introduction of the resectoscope. That is the only thing I use it for, because I think
Okay.
with this Stowe's Bertocci system, it has the teardrop outer sheath. So it's
Outer
very
sheath.
easy to, yeah. So it's very easy to align it. Plus, what we sometimes do is we do a gentle rotation of the scope, so it slowly helps to negotiate that internal loss, which is sometimes slightly tight. So definitely I do not prefer to use a Hager's dilator. If I'm using a Hager's dilator, I would rather retrofill the bladder and do it under guidance. Another thing which you need to do is you need to check your ultrasound report as well. Is there any suspicion of any adhesions? Because in my initial days, I remember around 4 5 years 6 years back, it had happened that I had taken up a hysteroscopy case, but it turned out that her endo was very thin, and she turned out to be a case of almost complete obliteration of the cavity with adhesions. So I remember back then that I had a great deal of difficulty in entering, and ultimately I had to use a Hager's dilator. So prior
Okay.
preparation for such surgeries is the only way out, or the best way out, rather, I would say. So you can use an
So
ultrasound to aid them.
ultrasound is really helpful, no? Helpful.
Yes, yes, yes. You can do wonders with an ultrasound, even during surgery also. Yeah. Then you can, of course, use this cervical preparation, that is 200 to 400 mics of misoprostol can be given to reduce the chances of difficulty in entry. And you can use a micro instrument tip to dilate the os and gain entry. This is another thing. Then Hager dilators, which you used about, it is better to be very cautious when you're using them. And of course, misoprostol is there. So Now we'll come to another topic, that is hysteroscopy in RIF for recurrent implantation failure. So since you also have your own IVF practice, so I'm pretty sure you have come across this patient, this category of patient wherein you have transferred say 2 times, 3 times, 4 times, 6, 7 good grade 1 embryos, but they do not seem to conceive. So what about hysteroscopy in them? Suppose you have a normal looking uterus and your 3D scan is fine, no other prior history, everything is great, endometrium is good, no issues, but not able to conceive. So would you like to go in for a hysteroscopy, Dr. Anam, or would you just like to rely on your
In case
ultrasound
of
and
repeated IVF failure, I must do actually thorough
yeah.
evaluation of the
Yes, yes.
endometrium.
So I totally agree with that. But then there are some studies which says that I'll show you. So this was the trophy trial, which shows that in recurrent in vitro fertilization failure, in this RCT of almost 650 patients, which shows that outpatient hysteroscopy with a normal uterine cavity does not improve the live birth rate. So that is ultimately what we all work for. It's not just the clinical pregnancy rate, but even the live birth rate. So that was one study. Then another one came out in 2019, which was quite an exhaustive study, which reviewed almost 4,000 subjects. They showed that there was an implantation in clinical and clinical pregnancy rates and implantation rates. So basically, this is something that we have to tailor according to our own practice, is what I feel. So as soon as we move away from first IVF to a repeated IVF for the second or third cycle, we definitely should think about doing a hysteroscopy. Is
But
what I
in
feel.
case of your opinion, in case of repeated IVF failure,
Yes,
when you are doing the hysteroscopy, what type of actually abnormalities you
finding.
find?
Yes. So many times, what we find is that we see these chronic endometritis features. You have these micro polyps. There is different kind of vasculature. Sometimes there
What
is
is the
small.
sign of chronic? What is the sign of chronic endometritis in
Say
the
you will have
hysteroscopy?
this hypervascular areas. You may have these micro polyps. So these are some of the signs. Very small polyps will be there. You may not pick them up on an ultrasound, but then they are very typical. And the endometrial vascularity may be very poor. So all these some such signs are there. Plus some amount of adhesions. I'll show you a case, in fact, which had a
Okay.
normal ultrasound picture. The 3D was perfect, no issues. And she had an IVF cycle outside, and she came to us with this one IVF failure. So we said, okay, since you have a failure, hysteroscopy has not been done prior, so let's go for a hysteroscopy first, and then we'll decide the course of management. Now, this particular lady, she had some other history as well, a history of PID, and I think she had a history of tuberculosis in her childhood. I'll be showing that case shortly. Yeah, let's just summarize. So what all we have seen today. So 3D ultrasound is an effective tool which helps us to make a good diagnosis of a pathology as well as to avoid unnecessary hysteroscopy. Of course, SIS as well. Hysteroscopy has revolutionized the management of Mullerian anomalies, and it is beneficial for RIF at least, but it is not for all cases of IVF. And pathologies like submucous myoma, intrauterine adhesions can be effectively managed by hysteroscopy. So let's just have a look at those cases which I talked about. One was, now this is of something which is a small cavity basically. So we had this patient who had the uterine size was quite small on USG also. So she had a prior failure. So we had gone in for a hysteroscopy, and if you can see, the cavity size is quite small. This is just maybe a 3 to 4 diameters of the scope is all that it would accommodate. Whereas if you see a normal uterine cavity is generally, this is a little bit tubular as well, if you notice.
Right.
Yeah, and so we went ahead and we did a little bit of a lateral wall metroplasty, and with just, of course, with cold scissors only. I'm pretty sure
Okay.
you use, for such cases, you also use the cold scissors, right, Dr. Anna?
Right. Here, definitely you will prefer cold scissor only.
Yes, yes. So we did a little bit of fundal cutting as well, and
How much?
we went.
Literally, how much? What is the guideline actually? What is the cutoff point that you have?
there is no cutoff point. Basically, you just need to give a little bit of a cut. You shouldn't be doing very deep cutting. As soon as you're
No, no.
able to see the ostia in one line.
You are cutting only the endometrium or some
No, no,
myometrium
no, no.
also?
Some amount of subendometrial cutting we have to do if you actually want to increase the area, because endometrium will build and it will shed off. So basically, if you're able to see the ostia in your view without, if you're able to see your ostia, then you do not need to do that lateral cutting. That is how it is. But
In this case, is there any chance of severe bleeding after cutting?
no, no, no. We generally, what happens is these cuts which you make are not so deep as it seems on the picture, but and the bleeding, we till date, touch wood, we have not had any such cases wherein they had very severe bleeding. So basically, the reason is that the uterus, it sort of compresses on itself, and if you feel that the bleeding is heavy, then you can just give a bit of a uterine massage, and it generally works. And
Okay.
we have, yeah, basically you should not cut so deep. The guide is that you should not cut into those vessels which you see. Now in this case, if you see, we are beginning to see a minimum amount of pink tissue as well. So once you do not, now you can see that vessel, so we will not go beyond that vessel. So that is the
Yeah. The
basic
question is cutting the lateral wall. So, is there any chance of adhesion actually that can
yeah.
cause
So
iatrogenic adhesion?
no, the chances, we have not seen those. In fact, we have seen slightly improved outcomes. Now, we use this same approach when we are going ahead with this one as well. When we go ahead with,
Another question is you are doing the lateral metroplasty in that cycle. So, when you are going to transfer embryo transfer?
see, when we plan for the embryo transfer, once after this, we take at least 1.5 to 2 months. It's just like an adhesiolysis only. So if we
Okay.
have the embryos, the way we mostly do it is we go for the hysteroscopy prior to the cycle mostly. We do not do it after embryo formation. It's only in cases of where we have, severe Asherman's or something, that we do plan for a one, we might do prior. Then if we see a good improvement in endometrium, only then do we generally proceed for the case, because some patients unfortunately do not improve. Coming to that, do you use PRP in your practice?
I'm not yet actually used in PRP, but I am planning to start PRP. Planning. But
Okay.
what is your opinion about the PRP treatment in case of
I,
Asherman or CV? Huh?
I, I think it is good. It
Okay.
does help, but most of the papers suggest otherwise. Just a moment. I'll share a video, one more video which I have. Uh, this is that case which I was telling you about. There was a minimal amount of this adhesions, which you can see. This is osteal adhesions, and you can see the color of the endometrium. It's really pale. If you see
Hmm.
on both the ostia, you can see the adhesions.
Hmm.
See this band of adhesions. So basically, this was
So
the
this
case.
type
It
of
was,
addition is it tuberculosis or other?
yes, there is a possibility. We have sent her for tuberculosis testing, but
Actually,
we have yet to.
is there any characteristics or features of the tubercular
Yes, yes.
addition or
Sometimes we
tuberculous
have
endometrium?
seen that. Yes. So basically, what we have seen is in full-blown tuberculosis cases, we generally see a very poor endometrium, and there'll be very
Okay.
thick adhesions when it is really when you get it in the later phases. Of course, earlier what we used to say was you should do a pre-menstrual DNC, is what pretty sure that many practitioners still follow it. Do a pre-menstrual DNC so that the tubercles, they come to the top, and then but then you have that much chance that already TB is there. You are doing a curettage with a sharp instrument, and then you are leaving out raw surfaces, and then that is just going to adhere. So there is no role of DNC in any case. So if you're suspecting a TB, you may have very pale endometrium, you will have adhesions. So these are the basic things, and you may have these calcified like nodules occasionally. But another thing that Dr. Anand, which I would like to tell you about is, means this is my personal means from some experience which I have. I'm telling you, if you have any case who have had a recent pregnancy loss, then you should definitely go for a hysteroscopy. Earlier, we just used to rely on the 3D, but we have seen in the last maybe these cases are fairly recent. In the last few years, we have seen around 6 to 7 cases wherein there was some amount of some uh, remnant of the chorion, chorionic reaction and all that, is some remnant is there sometimes on the lateral wall, sometimes back in the cornu. So they can really affect the chances of your conception as well. So if you have a pregnancy loss first trimester, second trimester, do a good ultrasound. You may have to go in for a removal of the products of conception by this one as well, by a hysteroscopy, and you can do a good guided one. So you can be very sure that okay, it's clear now. That would be really beneficial to the patient. So I think that about sums about everything that we have to see. And
right, it's a good discussion, right? You have actually completed all the things about the histoscopic evaluation.
yeah.
Oh, you didn't only put the myomectomy, no? In endometrial myomectomy, you have no video, I think. So,
Yeah, I don't have any videos. We are undergoing some IT processes, so all the videos and the hospital only.
experience. Do you have any experience of the Strassman metroplasty and IVF?
No, no, no.
No, it's a very rare thing, I think.
Yeah, that is gone now. That we don't do that. Means I have not come across anything.
Acha. That's thing. In case of actually very bad addition and what we are saying about PRP, actually how you put the PRP therapy after adiosolysis, how much you are giving
So
PRP? How you
what we generally use is we have this we have developed our own in-house thing wherein we after the surgery we call the patient say 6 days 7 days later, and we give 2 to 3 cycles of PRP over 3-4 days.
continuing the estrogen also the same?
Yes. We continue the
Estrogen
estrogen.
and you are also giving the PRP.
Yeah. So this is more of a it is more of what you can say something we are trying to help to improve the uterine the endometrium. It does not always work, but we have seen promising results in many patients. So we are quite hopeful with PRP. So basically, what is the endometrial cutoff that you take, Dr. Anam, before this thing?
Which one?
Before embryo transfer, what is the endometrial thickness cutoff that you take?
I think at least 7 must be there. What do you say? Hello, Rinoy. Hello. 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 I think some internet problem is there.
Yeah, I'm back. Yeah, I think there was a connection issue.
Some connection failure, I think. What I'm asking actually, what is the actually? I think before embryo transfer, at least 7 millimeter of thickness you must have. What do you say?
Yeah, definitely. 7 mm is a benchmark. But yeah,
actually,
but I think in the thin endometrium,
I had a bad experience. One of our doctor colleague actually, she had a very bad experience that she had endometrial curettage due to abortion. Actually, due to abortion, she has history of DNC, and that adhesive dense adhesion was there. In Bangladesh, she had one surgery. Then Dr. Sandesh also did surgery in Solapur. I referred her. Then again she had addition. Then she also going Indira IVF Delhi also. There also she had a surgery, but actually she at least she has no result actually. Very bad type of metal addition she had. She's a doctor.
So basically, in such there are those cases. Like I said, it's for example, when I was talking about PRP, if you look into evidence, there is not much anything very strong which will say that it can have a very positive effect and all. When the literature, if you review, it is not very promising. But on a case-to-case basis, if you say there have been positive outcomes in cases of PRP, but then there are those cases which do not respond, and unfortunately, there is no foolproof therapy for that at this moment. A stem cell injection has been tried. A lot of things are being tried.
Stem cell works in that cases.
It has worked in some cases, but it does not work for all. There is no
ultimately actually surrogacy is the only.
Ultimately, surrogacy is the only thing that we can offer that person.
Problem is your government has put some laws now. So our patient was actually very bad luck that when she developed that type of problem, your government banned the surrogacy, foreign surrogacy. So actually very, very bad thing happening with this doctor lady actually. So thank you, you have joined my show and you enlightened my show. Actually, you are very good. You actually, when I call you, always you help me. So thanks a lot. You will hope you will in future come to my show and we'll talk in different aspects of infertility. Thank you. So thank you. Thank you.
Thank you, Dr.
Would you like to say anything about our Bangladeshi audience or doctors?
No, I had been to Bangladesh about back just before the lockdown. It was in February. I'd come with my wife over there for the MRCOG exams. So it was a very nice experience, I would say. It is just a reflection of our country only, I would say. And it's just that there is a border in between. Baki, I think pretty much everything is the same. I was telling
same people, same culture, same food.
Yeah, yes, you just take a half-an-hour flight over the border and you're in India. You come back, you're in Bangladesh. That's the thing. So it was a very nice experience, and people are nice, basically.
Right. So thank you, Rinoy, and thank you, Rinoy.
Yeah.
Stay blessed. Stay safe in this corona.
Yes. Are you you're continuing your cycles and all right now, Dr. Anam?
Oh no. I just stopped the cycle. I am planning to start cycle within 1 and 2 months. Actually, I'll start cycle.
Okay.
Thank you, Rinoy. Thank you. Good night.
Okay. Yeah.